reduction in the quality and quantity of the follicular pool in the women of the reproductive age group. But in case of the ovarian aging, is a physiological process that causes a reduction in the quality and the quantity of the oocyte. Ovarian reserve is the limiting factor for the success of any treatment modality for the infertility which needs to undergo IVF to achieve the pregnancy. Success is the low despite a plethora of intervention and is associated with the high pregnancy loss and increases the need for the egg donation. Molecular criteria have been introduced the following the consensus meeting of the SC working group and for definition is held in 2021. Molecular criteria recommend the presence of at least two of the following three factors for the diagnosis of the ovarian reserve. Advanced maternal age more than 40 years or any other risk factor for the ovarian reserve, any previous ovarian reserve less than 3 oocytes with the conventional stimulation protocol, and abnormal intracellular. Okay. In the working in group of the ovarian reserve held in the 2011. Molecular criteria recommended the presence of at least two of the following three features for the diagnosis of the ovarian reserve. Advanced maternal age more than 40 years or any other risk factor for the ovarian reserve. And a previous ovarian reserve at least less than 3 oocyte with the conventional stimulation protocol and abnormal emitter follicular count 5 to 6 follicle or AMH 0.5 to 1.1 nanogram per ml. Slight disturbance. It's the diagnostic criteria of the European Society of the Human Reproduction and Embryology, the age less than 40 years, the premature menopausal symptom and infertility and menopausal symptom just like the oligomenorrhea or amenorrhea, hot flashes and vaginal atrophy. And the biochemical marker that is the MH level is less than 1 nanogram per ml and the serum FSS level is more than 25 milli-international unit per ml and serum E2 level is less than 50 picomole per liter. And the transvaginal sonography shows the antral follicular count less than 5 follicle and small ovarian volume. That is the criteria for the premature ovarian failure by the SRI. And the management dilemma, there is a when the premature ovarian insufficiency, only the management is the oocyte donation, embryo donation, surrogacy, ovarian preservation, and adoption. And repeated gonadotropin therapy is a theoretical risk. So nowadays, the oocyte donation, embryo donation is not religiously all level, in all level are accepted. So we can go the next novel approaches. The novel approach is for the challenging the premature ovarian reserve with the PRP therapy. Premature ovarian insufficiency respond poorly to the ovarian stimulation. So-called the last and the most promising is the egg donation. Egg donation is not acceptable in our perspective due to the religious, cultural, or the ethical issue because the donated egg never a biological offspring. Intra-ovarian infusion of the PRP is a promising treatment. Now, what is the PRP? An autologous, highly concentrated solution of the plasma. It is discovered in the Harvard University. It is safe and involves no chemical and no risk of infection and virus transmission or allergic reaction. And it is prepared from the patient's own blood and contain a concentrated source of the growth factor. Restoring the function in ovary as well as improving the vascularization and regeneration, neovascularization, and healthy cell formation, and restore the folliculogenesis in the menstrual cycle. The PRP mechanism of action, when the PRP is introduced into the ovary, and it stimulates the angiogenesis, proliferation, chemotaxis, differentiation, and anti-inflammatory reaction. And the PRP is the novel therapy for the ovarian failure, ovarian reserve, and for the uterine lining. And how the functioning of the PRP is the high concentrated platelet rich plasma, that is the plasma containing the fibroblast growth factor, platelet derived growth factor, epidermal growth factor, and transforming growth factor beta. And the platelet-rich plasma extract has a number of the growth factors that can help the ovarian regeneration and restore the normal function of the ovary, help to form a new precursor cell and interaction with the stem cell and leading to the correction of the creation of a mature egg. And the platelet-rich plasma are, first of all, is the sample is the collected from the patient, and the first centrifugation, then the platelet, WBC, and the RBC are separated, and the upper layer, that is the platelet and WBC contain, and the lower layer, that is the RBC. And second setting, that is the transferred to the second test tube, that is the platelet and WBC, and with the Buffy coat is transferred in the second test tube, and then second centrifugation was done, and then the upper layer, the poor platelet-rich plasma, and in the lower layer there is the high platelet-rich plasma was found. And the Reproductive Endocrinology and Infertility Department of the Bangladesh, Sheikh Mujib Bangabandhu Medical University, is probably the first IVF center in the Dhaka, Bangladesh, to include the PRP therapy for the management of the poor ovarian reserve. For those considering the ovum donation, BSMMU PRP therapy for the ovarian rejuvenation may be a worth and try again. And the success rate of the PRP therapy is the more, and that it is the average to highly cost-effective available treatment option in case of the donor in vitro fertilization. And rationale of the research, as a result, there may be increased ovarian reserve by promoting the follicular growth and better ovulation and pregnancy rate. Thus, we can avoid the need for the ovum donation in the premature ovarian failure women. In this context, PRP therapy, therefore, ART must be a great hope for the premature ovarian insufficiency in infertile women as well as for the fertility experts. Objective, general objective is the effect of the PRP therapy on poor ovarian reserve. Specific objective, that is to measure the baseline serum FSH AMH level on the day 2 and observe the AFC count on the day 5 of the administration before the PRP therapy. And measure the serum FSH AMH on day 2 and observe AFC count on the day 5 in the first cycle, second cycle, and third cycle of the post-PRP. And to compare the serum FSH AMH and the AFC count with the basal level. That is the specific objective. The materials and method, study design, prospective observational study. Total 72 cases were selected. Among them, the 12 patients had lost at the follow-up time to the study. So the total 60 patients are enrolled in this study. Place of study at the Reproductive Endocrinology and Infertility Department in the BSMMU Dhaka, and during the period of the July 2019 to June 2022. And the study population was diagnosed the poor ovarian reserve woman with the subfertility having the AMH level less than 0.7 nanogram per ml and FC count less than 5 in the both ovary, according to the inclusion-exclusion criteria set for the study. And the sample was the 70, but there is a 10% drop, and the total 60 patients was enrolled in this study. Selection criteria, inclusion criteria, woman is between the 25 to 40 years, AMH level less than 7 nanogram per ml, and FC count less than 5 in number included in the study. And exclusion criteria due to the genetic origins such as the Turner syndrome or the chromosomal abnormality are excluded, or the patient suffering from the patient on the anticoagulant therapy, or there is a chronic disease are excluded from this study. Materials and method, that is the primary we see the primary outcome variable and the secondary variable. Primary outcome variable, we see the biochemical changes in the post-PRP therapy. Serum FSH and AMH level and the AFC count was observed post-PRP. Secondary outcome, after pre-anesthetic checkup with the counseling and informed written consent for the laparoscopic tubo-pituitary evaluation under general anesthesia was taken. During laparoscopic evaluation, 5 ml of prepared autologous PRP was injected into the each ovary by the ovum pickup needle. After laparoscopy and the PRP injection, postoperative patient management was done accordingly, and advice was given for the monthly follow-up for 3 months on the OPD in the REI department. And PRP process, first the collection of the blood from the patient and centrifuge the blood and process and collect the platelet and inject the platelet into the desired site. Result. This is a prospective observational study, and the 72 patients are enrolled into the study, and the 60 were the follow-up procedure. AFC, AMH and AFC is rises, and the FSC is become low. Is the objective in the evidence of the ovarian rejuvenation is demonstrated. Parameter, the clinical data, and collected for the 3 years. And regarding changes of the menstrual pattern, pregnancy outcome, statistical analysis was done with the Microsoft Excel. And first, the distribution of the participant in the demographic and clinical parameter, the number of the 60 patient, and the age, mean age was 36.4 years, and the primary subfertility 72.46%, and secondary subfertility was 27.54%. And according as usual, that is the menstrual pattern was the normal menstrual pattern was 83.8%, and among the oligomenorrhea was 16.2%, and 5.9% had a family history of the early menopause. And the changes of the AMH and AFC value between the baseline in the first cycle. In the baseline AMH level 0.32 plus minus 0.16, and AMH is mean SD was 3.41 plus minus 0.73, and FSH was 10.57 plus minus 0.25. But in the first cycle, AMH level is increases and the 0.32 to 0.37, and FC count is the 3.4 to 4.7, and FSH level is the 10, but first cycle it was become a 8. So there is a main difference is the AMH and AFC count. There is a increase the AMH and AFC count, and FSH level is decreases. So it is the important things, that is the first cycle it was the all parameter as the in favor of improving the ovarian result. And in the second cycle, AFC and AMH level, the baseline in the second cycle. Here is the AMH level is increases in the second cycle, and AFC count is also increases, but FSH level is also decreases. And there is a more increases in the AFC count. In the upper limit is the difference is the 2.82. And the percentage of the AMH and AFC baseline with the different in the third cycle. And there is a AMH raised in the from the baseline to the first cycle is the 58.62%, and in the second cycle 86%. But AFC count is first cycle 55% and second cycle is the 79%. And in the FSH level is increases in the first cycle 67 and second cycle 89%, 81%. But in case of the third cycle, no change in the AMH level, that is the 86% patient are the third cycle AMH level and second cycle in the same. But in the FSH raised, AFC count is the raised is the from the second cycle to the third cycle, that is the 95%, and AFC count is raised. And FSH is also decreased from the second to the third cycle. There is a 92% decrease in the FSH count. And the result, there is the pregnancy status. It was observed that at the final level of final follow-up, the 12 patient was pregnant among the 60 patient, and that is the 12% have gotten the pregnant. And among them, the 3.3% of the patient had gotten an abortion, and 76.67% remained the non-pregnant. Human reproduction, the intra-ovarian injection of the platelet plasma in the assisted reproductive, 2 months too soon, and it was published in the July 2021. Working hypothesis that PRP may provide a readily accessible, individualized and cost-effective and pro-intuitive proliferative and the pro-inflammatory factor, which may stimulate the de novo oogenesis and or the follicle maturation. And another study, there is the ovarian rejuvenation therapy with the PRP, is an innovative solution of the women with the infertility. And in this, the Shah et al. Randomized clinical trial showed that the 51 subfertile women with the AMH level less than 0.5 nanogram per ml if the laparoscopic ovarian autologous PRP injection. And she showed that the increased the post PRP pregnancy rate is the 33.3%. In the discussion, the study was concluded to the total 60 patients in the ovarian reserve and the intra-ovarian prepared infusion on the improvement of the ovarian follicle who were properly followed up after infusion of the PRP in the duration of 3 months or the menstrual cycle. The mean increase in the AMH level and AFC count 58 and 55.17% respectively. And second cycle, it was the AMH level is the 86.2% and AFC count 79.3% respectively. But in the third cycle, AMH level varies does not any further rise, but the AFC value increased 95 to 6.5%. And it was observed that the final follow-up, 20% patient has got the pregnant and the 3.3% has gotten an abortion and 76% patient remained the non-pregnant. And another autologous platelet fertility society in the Israel and show the another journal that is the ovarian autologous therapy treatment improve the oocyte and embryo quality in women with the poor ovarian response. And here shows that the M2 oocyte quality and the blastocyst quality is significantly improved in the post-treatment period. And the PRP treatment is an effective approach in improving the oocyte and embryo quality in poor responder. A case sheet of the natural conception resulting on the ongoing pregnancy in the menopausal and premature premenopausal women in the platelet-rich plasma treatment. Here show that the primary outcome, the restoration of the menstruation, as well as the decrease in the FSCs and increase in the AMH level. And patient has achieved pregnancy naturally in the 2 to 6 months following the PRP treatment. Conclusion, that is the common disorder found in the 1% of the female infertility. Currently, the prevention and the treatment of the PRP are extremely limited. The study was observed significant improvement of the AMH and AFC value following the PRP infusion. The improvement of both values was gradual increase of the AMH level are observed up to the second post-PRP menstrual cycle. While the AFC increased in the third cycle and in post-PRP, and 2/8 of the patient had been pregnant in the final data collection and the study. The gold standard diagnosis is the change of ovarian hormone, and considering the diversity of the cell type and the function is required for the guidance of the further research in this field. Limitation of the study. This study was conducted in a single hospital with a small sample size, so the result may not represent the whole community. Participant and the investigator are not blinded to the treatment after randomization. RCT is needed in a large scale for further study. Recommendation and suggestion for further studies: further multicenter, large scale samples, large sample and long-term prospective clinical trial are required for the support the current conclusion. Further study are decided to control group are necessary to better understand the effect of infusion of the PRP among infertile participants. New therapeutic strategy, stem cell content such as the messenger RNA for the future care of the ovarian dysfunction such as the folliculogenesis and vascular formation and genetic stability. Some studies have observed even further improvement after combining the autologous bone marrow derived stem cell and PRP therapy for ovarian rejuvenation. Reference and conclude the session, and thank you all. Can you hear? Thank you.
Thank you, Dr. Jesmine. That was an excellent presentation.